Dear friends and colleagues, good morning or good afternoon, and welcome everyone. Uh, Before leaving the floor to our chairman, Professor Sogstad, and our speaker, Professor Satyan, I would like to inform you that from today and in the future, the webinar will no longer have the format of the past, that is, 3 lectures in the 3 successive days. This formula was chosen during COVID, but is currently no longer applicable due to the numerous commitments of the speakers, with the results of having long intervals between the various modules. So organizing one lecture at a time has the advantage that the organization will be much easier, and therefore a great number of webinars will be organized, and above all, more frequently. I take this opportunity to thank the speaker of today, Professor Satyan, for his availability, and I leave the floor to Professor Sogstad. Please, Ola.
Thank you very much, Professor Moretti. It's a great pleasure to welcome all of you to this Module 2 of this year's webinar, and the topic is pulmonary hypertension. And the speaker today is Satyan Lakshminrusimha. He is a very well-known neonatologist and international speaker. He is chair of pediatrics at the University of California, Davis since 2017. And before that, he spent 21 years at the University of Buffalo and was professor of pediatrics from 2011 to 2017. His primary focus is fetal and neonatal lung physiology, asphyxia, and pulmonary hypertension of the newborn. He's also interested in oxygen research, and he's editor of Essential Neonatal Ventilation, which I think is a new book coming out soon, or maybe it's been out already. He's published more than 100 medical drawings in pediatrics and neonatology for textbooks, the journal articles, and apps. So the topic, his topic today is management of pulmonary primary hypertension of the newborn. So it's a pleasure to leave the floor to you, Satyan. And before that, I just want to remind the audience about the Q&A opportunity, so you can send in your questions, and we'll have a discussion at the end of this session. So please, Satyan, welcome, and we're looking forward to listen to your lecture.
Professor Moretti, Dr. Luca, thank you so much for the invitation. Dr. Saugstad, really appreciate your introduction. Thank you very much. So we'll talk about the management of PPHN today, mainly pertaining to term infants. Before I start, here are my disclosures. And for the longest period of time, especially during my fellowship and before 2004, I was somebody who used a lot of oxygen while managing PPHN. Subsequently, I gradually changed to start using more and more inhaled nitric oxide, but not until much later did I realize the relationship between nitric oxide and oxygen. And majority of what I'm going to talk to you today is based on guidelines from the European Pediatric Pulmonary Vascular Disease Network, some from the Canadian Collaborative, and more recently, a book on pulmonary hypertension that Dr. Steve Abman and I were fortunate to edit. And this many illustrations that I will be showing you in this presentation are from this book. So the year was 2004. I was a young neonatologist trying to figure out as to what I should do, as to whether I should come back to academics or not. And during this time, there was a tendency to use 100% oxygen a lot in neonatology and during resuscitation of term newborn. And as I told you before, I was very fond of using 100% oxygen, and I thought that using more oxygen resulted in much more dilation of the pulmonary vasculature and reduced PPHN. And I was fortunate to hear a wonderful talk by Ola at PIS in 2004 in San Francisco, where he opened up my eyes and talked about the use of room air for resuscitation to avoid collision with hyperoxia. What is really interesting about the interaction between 100% oxygen and nitric oxide is that that's one of the key things that has led to improved outcomes in PPHN that we don't really recognize. If you think of it, this is the trend of annual ECMO use for meconium aspiration syndrome, which often is accompanied with asphyxia. So as you can see here, the gray bars are the babies who survived with ECMO and meconium aspiration syndrome. The dark bars are babies that died with meconium aspiration syndrome. As you see, this was the #1 indication for ECMO for many years. Subsequently, inhaled nitric oxide got approved in 1998 and started being used, and that led to some reduction in the use of ECMO. But as you can see here, there's a second dip in the use of ECMO for meconium aspiration syndrome, and this is when we started using room air for resuscitation in term infants, thanks to all the work done by Ola and his group. And that led to a further reduction in the use of ECMO for meconium aspiration syndrome. This goes to show that by association, inhaled nitric oxide and room air for resuscitation of term infants both had a significant reduction, led to a significant reduction in the use of ECMO. And so both of these are really credited with reducing the need for ECMO because it enhances the effect of nitric oxide. So when you talk about acute pulmonary hypertension of the newborn, also called APH, the spectrum is very wide in the newborn nursery. For example, there is acute PPHN in term, late preterm, and post-term neonates with hypoxic ischemic encephalopathy and meconium aspiration syndrome. We'll be focusing on this today. And there is also the combination of congenital diaphragmatic hernia that results in both acute and chronic pulmonary hypertension. We will not address this, although some principles do apply for CDH as well. The third entity is acute pulmonary hypertension in extremely preterm infants with PPHN physiology, and these preterm infants increasingly are being treated with inhaled nitric oxide. And we have chronic pulmonary hypertension with BPD, and that's very common as well. And lastly, there might be an association with pulmonic vein stenosis and BPD and pulmonary hypertension. So this is a fairly wide spectrum of pulmonary hypertension in neonates. But instead of using these type of classification, it's better to use a phenotype or based on physiology, because that's what helps us dictate optimal therapy in babies with pulmonary hypertension. For example, many of you are aware of the formula that mean pulmonary arterial pressure is equal to pulmonary vascular resistance times cardiac output plus pulmonary capillary wedge pressure. If you look at these individual components, all of them contribute to pulmonary hypertension. If you assume this to be the normal heart, right atrium, right ventricle, left atrium, left ventricle, typically the shunt across the PFO and the PDA is left to right, and the interventricular septum is bulging towards the right because the left-sided pressures are higher than the right-sided pressures. But when you have resistance-driven pulmonary hypertension where the PVR is high, you tend to see right ventricular hypertrophy, deviation of the interventricular septum towards the left, and a right to left shunt across the PFO and the PDA with reduced pulmonary blood flow. This entity is called as resistance-driven pulmonary hypertension. And the treatment for this is usually inhaled nitric oxide or pulmonary vasodilators. On the other hand, increased pulmonary arterial pressure can also be due to increased cardiac output, where you have high pulmonary flow, and that high pulmonary flow in turn results in pulmonary arterial hypertension. And a classic example of this is flow-driven pulmonary hypertension seen with vein of Galen malformation in the head. And so this is a condition where inhaled nitric oxide can further increase pulmonary blood flow and cause worsening of the condition. The third entity is when you have left ventricular dysfunction or pulmonic vein stenosis. This results in increased pulmonary capillary wedge pressure, and this is called post-capillary pulmonary hypertension or pulmonary venous hypertension. And in this condition, interestingly, you see a right to left shunt across the PDA because the pulmonary arterial pressure is high, but you see a left to right shunt across the PFO because the left atrial pressure is high due to left ventricular dysfunction. And this is commonly seen in LV dysfunction or pulmonary vein stenosis. And in this condition, giving inhaled nitric oxide can increase pulmonary capillary wedge pressure and increase pulmonary edema. So knowing the exact phenotype to which the patient belongs will help us decide to adjust the management of pulmonary hypertension more than the previous slide I showed you, where the etiology is based on gestation and physiology. So a physiology-derived pulmonary phenotype will help us decide the optimal management of PPHN. So how does a fetus thrive with severe pulmonary hypertension? The fetus has several secrets that helps it survive this period. The first is that a fetus is almost like a parasite. It extracts every bit of oxygen from the mother and survives and thrives really, really well. It maintains a high hemoglobin, and that's a lesson for us to maintain a decent hematocrit while managing PPHN. High levels of fetal hemoglobin are very helpful, and for that reason, delayed cord clamping is really important in managing babies with PPHN. The lungs in a fetus are maintained at functional residual capacity with lung liquid, and so is the importance of optimal lung inflation while managing PPHN. A baby with a fetus also has normal systemic blood pressures with low LV afterload, and so it's important to avoid excessive systemic hypertension. And maintaining ductal patency to reduce RV afterload is really important, and that's where the use of PGE1 comes in while managing PPHN. And finally, a fetus clearly knows that giving optimal oxygen and delivery of oxygen is more important than maintaining a very high PaO2 or SpO2. So optimal oxygen use, focusing on oxygen delivery to the tissue is also an important lesson while managing PPHN. So let's talk about the unique aspects of fetal hemoglobin. As many of you know, this is the oxygen dissociation curve with PaO2 on the horizontal axis and saturation on the vertical axis. And the red line here represents adult hemoglobin, HbA, and the purple line here represents fetal hemoglobin, or HbF. When you are normoxemic, say you have an arterial PaO2 of 80 and a venous PaO2 of 40, then adult hemoglobin is a very effective mode of delivering oxygen. That's where you and I live, and that's what we use for oxygenating. On the other hand, if you have a baby with PPHN or hypoxemic respiratory failure who is hypoxic with a PaO2 down in the 40s, with the venous PaO2 being down in the 20s in this blue zone, then it's very clear that the adult hemoglobin is not that effective in delivering oxygen, whereas the fetal hemoglobin, because of this curve, has a much higher arteriovenous difference in oxygen. So during hypoxemia, a fetal hemoglobin is a much more effective agent to deliver oxygen to the tissues than adult hemoglobin. So preserving every molecule of fetal hemoglobin is really important. And as you can see by the dashed hyphenated line here, even during hypothermia, this becomes really important. So cord placental transfusion and preserving fetal hemoglobin is really an important aspect of managing PPHN. So let's talk about a baby who is born at 39 weeks of gestation to a primary gravida mother. She was a smoker, had thick meconium-stained amniotic fluid. Infant is floppy and apneic and is not vigorous. And nowadays, we don't do tracheal suctioning in these babies. But what do we do with cord management? Should we immediately clamp this cord and deliver this baby and resuscitate this baby? Should we defer cord clamping for around 60 seconds? Or should we try out cord milking? These are the three options we have. And most of us consider doing immediate cord clamping in these babies, but there is some recent data to suggest that cord milking might be an option. So what is cord milking? Intact cord milking is where you have the baby still attached to the placenta, and you go ahead and strip the umbilical cord so that the blood inside the umbilical cord and the placenta is pushed towards the baby. In rapid succession, you do it like 4 times, and that results in delivery of fetal hemoglobin to the infant in a quick time without delaying resuscitation. And is this beneficial? The answer to this question was given to us by Dr. Anup Khateria in a recent study called as the MINVI study, where he showed that milking the umbilical cord for 4 times compared to early cord clamping resulted in higher hemoglobin and reduced in the incidence of moderate to severe HIE, reduced the need for therapeutic hypothermia in this large trial. There was no difference in death before discharge or NICU admission for this indication. But if you have a baby who is non-vigorous, this might be one method of placental transfusion. Anup went on to show a few other changes in babies that have received cord milking. In babies that have undergone cord milking, he showed that the left ventricular output was significantly higher, The red numbers here are with cord milking. The blue numbers are with early cord clamping. And the SVC flow was much higher. And interestingly, the RV output was much higher in these infants. And these infants needed much lower FiO2 compared to infants that underwent immediate cord clamping. So this goes to show that cord milking might have some benefit by enhancing cardiac output and resulting in lesser need for oxygen in babies who are born less vigorous. In fact, there have been studies to show that cord milking or placental transfusion with delayed cord clamping might have some significant effects on pulmonary vasculature. This is a study way back from 1966 by Dr. Arcila and Bill O. What they did in this study was they randomized term infants born by vaginal delivery into either the late clamp group, where they waited for umbilical cord clamping for 3 to 5 minutes, or the early cord clamp group, where they immediately clamped the cord over 2 to 10 seconds. And what they showed was that if you clamp the cord early, the pulmonary arterial pressure to aortic pressure ratio decreases very rapidly in these infants. On the other hand, if you clamp the cord late, in fact, the pulmonary arterial pressure remains high and subsequently falls down, showing that increased blood flow to the pulmonary circulation occurs following delayed cord clamping. And although it might maintain the pulmonary arterial pressure slightly higher than otherwise, it results in much more effective transition during a birth. And this is really effective in enhancing oxygenation. So delayed cord clamping might have benefit in these babies. So going back to the cord milking, the gestation is really important with cord milking. If you're a preterm baby, cord milking is associated with increased risk of intraventricular hemorrhage and should be absolutely avoided. On the other hand, if you're between 28 and 32 weeks of gestation, if you're moderately preterm, there is neither benefit nor any negative effects of using cord milking. On the other hand, in babies 35 weeks to 42 weeks of gestation that are non-vigorous, milking might reduce hypoxic ischemic encephalopathy and reduce the need for therapeutic hypothermia. So the effect of cord milking are dependent on gestational age and should be avoided in extremely preterm infants. So moving on, here is our baby, was transferred over to the NICU on 60% oxygen, but required more and more oxygen, and subsequently was tachypneic and had an arterial gas of 717, a PCO2 of 20 because the baby was breathing so fast, and a PO2 of 124 and minus 19 base deficit. The preductal oxygen saturations were good, but the baby was shunting postductally. So what's the effect of this hypocarbia and hyperoxia in babies? The answer to this question was given to us by one of our close friends, Dr. Vishal Kapadia. What he did was he looked at babies' first gas following resuscitation, and he checked and saw the arterial PO2 on that gas. If babies had a first gas with a PO2 of less than 100 millimeters of mercury, these babies had a low incidence of hypoxic ischemic encephalopathy. On the other hand, if babies had a high PaO2 or more than 115 millimeters of mercury, these babies had a much higher incidence of hypoxic ischemic encephalopathy, showing that perinatal asphyxia combined with postnatal hyperoxia can be associated with a higher incidence of hypoxic ischemic encephalopathy. So it's really important to avoid hyperoxia in these babies that are undergoing birth asphyxia, even postnatally. The second thing that was shown by Athena Pappas and Dr. Sita Shankaran in their trial was it's really important to avoid hypocapnia or low PaCO2 less than 35 millimeters of mercury. If the exposure to low CO2 during the first 72 hours of life is high and it's in the 75th percentile, these babies have a much higher incidence of death or neurodisability at 2 years of age. On the other hand, if the babies are not exposed to any hypocapnia, their incidence of death or disability is much lower. So it's important to recognize that hyperoxia in the immediate postnatal period is bad. Hypocarbia is also bad in this time. And so both of these should be avoided. And so having optimal CO2 is very important. And we should avoid low PCO2 less than 35 millimeters of mercury corrected for temperature while managing babies with HIE and PPHN. So the third question is, when you have base deficit like this, is there any point in using bicarbonate, or is this bicarbonate a baseless therapy? It's important to realize that giving a big load of bicarbonate to correct base deficit can be associated with reduced cerebral blood flow, because bicarbonate does not cross the blood-brain barrier, but CO2 does, and it can cause worsening of intracellular acidosis. So if at all you use bicarbonate in such babies, a very small dose should be used, like 0.5 to 1 milliequivalent per kg, should be infused extremely slowly over a period of 30 to 60 minutes, and that might help in improvement of pH and pulmonary vasodilation. And large doses of bicarbonate should not be used in babies with PPHN, even though they're acidotic and this can cause intracellular acidosis and problems. So if at all you use bicarbonate, use very small doses. It's important to realize that many of us tend to use fluid boluses while managing these infants, and it's a common practice to use fluid boluses that contain normal saline, but normal saline can be acidotic, and so consider using boluses of Ringer's lactate, because Ringer's lactate tends to go into the body and infuse lactate, and lactate goes through the pyruvic acid cycle, TCA cycle, and produces more carbon dioxide. So using Ringer's lactate might be a better option as long as the baby's lactic acid levels are not high. I would always prefer to use Ringer lactate for fluid boluses while managing babies with PPHN. This baby further went on to require whole body cooling, as it's a common in many babies that have HIE now. It's standard of care. It's important to remember that cooling a baby in the presence of pre-existing parenchymal disease such as meconium aspiration can result in aggravation of pulmonary vasoconstriction. And this can be aggravated both during cooling and also during rewarming, because during rewarming, you can see some element of systemic hypotension in these babies. So it's important to recognize that cooling, especially when it goes below 33 degrees centigrade, can exacerbate pulmonary hypertension and worsen oxygenation. So cooling must be taken very seriously in babies with PPHN, because that can worsen oxygenation in these infants. So when you have a baby that has gone through perinatal asphyxia, watch for these findings, because these can predict PPHN. A baby with severe asphyxia, or a baby who required chest compressions, especially if they required the use of epinephrine, or if the baby is having pre-existing lung disease such as meconium aspiration syndrome or pneumonia, or if the baby requires more than 50% oxygen prior to the onset of cooling. If you have any of these 4 conditions, you should be very careful with these babies, because these babies are at high risk of developing pulmonary hypertension and should be carefully watched. In fact, Dr. Shankaran has shown that if with babies with asphyxia that are treated with normal temperature of 37 degrees centigrade, the incidence of PPHN is around 22%. But when they're cooled to 33.5 degrees centigrade, the incidence of PPHN is around 25%. And if they undergo deep cooling, which might occur sometimes during passive cooling, the incidence of PPHN is much higher at 34%. So in other words, 1 out of 4 infants with HIE undergoing standard hypothermia has PPHN. That's very high incidence. And 1 out of 3 infants with HIE undergoing deep hypothermia to 32 degrees centigrade has PPHN. So PPHN, although it's only seen in 2 out of 1,000 normal term infants, is seen in 1 out of 4 infants undergoing cooling. And this incidence is very high and should be carefully watched for. Why is it that we see so much of PPHN during cooling in babies with asphyxia? A combination of delivery room medications, perinatal asphyxia, and presence of parenchymal lung injury tends to put these babies at risk for pulmonary vasoconstriction. Then, because of the high RV afterload, there is some degree of myocardial ischemia, and these babies tend to have cardiac dysfunction that also contributes to pulmonary vasoconstriction. And finally, therapeutic hypothermia itself can be a pulmonary vasoconstrictor, and all these factors contribute to pulmonary vasoconstriction in PPHN in these infants. And respiratory depression from HIE can cause hypoxemia, ischemia, and acidosis, and also contribute to pulmonary hypertension. So there are it's multifactorial etiology that contributes to pulmonary hypertension in asphyxia. So one of the common agents that we use for treating asphyxia for pulmonary hypertension is inhaled nitric oxide. The beauty of inhaled nitric oxide is that it is an inhaled vasodilator that only enters ventilated alveoli and does not enter non-ventilated alveoli. So it dilates blood vessels adjacent to a ventilated alveolus, but leaves the non-ventilated alveolus alone. So that results in improved ventilation perfusion matching, and that's why it can increase oxygenation in babies with pulmonary hypertension and parenchymal lung disease. It's important to remember that nitric oxide is selective. It does not cause systemic vasodilation, so there is no systemic hypotension with inhaled nitric oxide, and it's microselective. It only goes to ventilated alveoli, and so both the selective and microselective effects of inhaled nitric oxide results in improved oxygenation. But it's really important to know that transient improvement in oxygenation after starting inhaled nitric oxide does not confirm pulmonary hypertension. Even babies with parenchymal lung disease can show small improvement in oxygenation because of ventilation perfusion matching. And so even babies without PPHN may show as transient improvement. So that's something to recognize while using inhaled nitric oxide. So some babies respond to inhaled nitric oxide, and we've shown that inhaled nitric oxide increases PaO2 levels. Inhaled nitric oxide results in reduced FiO2 in many babies. Inhaled nitric oxide results in sustained improvement in oxygenation, and inhaled nitric oxide can lead to hemodynamic improvement and reduces the need for ECMO. But close to a third of babies do not respond to inhaled nitric oxide, and there are few reasons as to why inhaled nitric oxide is not effective in some infants. The most important reason, in my opinion, is that when you give inhaled nitric oxide, it is not reaching the target organ. The target organ for nitric oxide is the pulmonary arteriole. If inhaled nitric oxide does not reach it because the lung is not recruited, these babies will not respond to inhaled nitric oxide. So, for example, if you have a lung that's looking like this, giving inhaled nitric oxide here will not help this baby. The lung has to be opened up, and only after opening up the lung will there be a response to inhaled nitric oxide. So inhaled nitric oxide has to go through the alveolus, reach the pulmonary arteriole for it to act. So the target is here, and if you don't open up the lung, inhaled nitric oxide is not effective. So for example, if you're using an alveolus that's completely collapsed like this, and there is an over-distended alveolus, in these babies, giving inhaled nitric oxide only results in partial improvement because this alveolus is not open. On the other hand, if you use surfactant and open up the alveolus, then there is symmetric expansion of the lung, and nitric oxide can reach all these alveoli, resulting in uniform pulmonary vasodilation. So lung recruitment and possibly using surfactant is really important. Do we have any data to show that surfactant is effective? Here is some data from Chile, where Gonzalez and colleagues have shown that using a dose of surfactant and then subsequently giving nitric oxide results in a much more significant decrease in oxygenation index compared to using nitric oxide alone. So opening up the lung and using surfactant is very effective. And in some babies with meconium aspiration syndrome, they also have surfactant inactivation and may benefit from repeated dose of surfactant as well. So one more X-ray to show you. Here was a baby from Kaiser North that was treated by Dr. Tree Nguyen. What he showed was that the lungs were collapsed like this. Giving 81% oxygen and inhaled nitric oxide didn't really help much. But once he removed a mucus plug and opened up the lungs, then the baby's oxygen came down to 41%, and subsequently nitric oxide could be weaned off. So opening up the lungs is really important prior to using inhaled nitric oxide. So many of you have heard the story of the blind man and the elephant, where blind men were touching an elephant and thinking that they were touching a snake, touching a python, touching a wall, touching a fan, etc. But they didn't really realize that it was an elephant because the elephant was so big. Similarly, while treating a baby with PPHN, it's important to recognize that there might be parenchymal lung disease that requires oxygen and surfactant. There might be hypotension requiring vasopressors. There might be high pulmonary vascular resistance requiring inhaled nitric oxide. There might be cardiac dysfunction requiring IV milrinone, and there might be HIE requiring therapeutic hypothermia. It's important to take a big picture, take a step back and see what's going on, and then treat all these conditions while we are treating the whole baby. Because PPHN is a dynamic disease, and within a minute, things can change around and cause many changes, and that may result in change in management. So constant monitoring is really, really important while managing babies with PPHN. So the second thing that we need to do while managing PPHN to enhance the effectiveness of nitric oxide is avoid oxygen toxicity and optimize FiO2 and PaO2. So gentle ventilation and targeting prerectal oxygenation are really two important things that we need to do. And I personally believe in using preductal SATs of around 90 to 97% and postductal SATs above 80% while managing babies with PPHN, as long as the babies have normal lactate and an adequate urine output. I also monitor all these babies with NIRS because that gives you a better indication of oxygen utilization by the brain and the tissues. So most babies that have PPHN should be hooked to NIRS so that we can monitor cranial as well as somatic oxygen extraction. The third thing to remember is that both oxygen and nitric oxide are very powerful pulmonary vasodilators. So it's almost like the marriage between oxygen and nitric oxide is made in heaven. But if you give too much of oxygen, especially above 60% oxygen, you then result in formation of superoxide anions. And when nitric oxide and superoxide anions combine, they tend to cause peroxynitrite that results in vasoconstriction. And as you can see in a LAMP study here done by Wedgwood and colleagues, ventilation with 100% oxygen for 24 hours resulted in a lot of green substance here. And this is 3-nitrotyrosine, the toxic peroxynitrite. On the other hand, if you ventilate lamps with 100% oxygen and 20 parts of nitric oxide, even more peroxynitrite is formed, not only in the pulmonary arteries, but also in the airway over here. If you use intratracheal recombinant superoxide dismutase and quench the signal for superoxide anions, then you see a significant reduction in peroxynitrite formation. But since we don't have access to superoxide dismutase, if you ventilate and wean the oxygenation, reduce oxygen rapidly and bring the FiO2 below 0.6 and maintain PaO2 between 50 and 80 millimeters of mercury, then also there is significant reduction in peroxynitrite formation. So leaving babies on 100% O2 for long periods of time is not good. And it's good to wean the oxygen as soon as you can to bring the FiO2 below 0.6. And we have also shown data in LAMP studies that in lamps with PPHN, where the pulmonary vascular resistance is pretty high, whether you use 100% oxygen shown in red, 50% oxygen shown in orange, or 21% oxygen shown in green, whatever the FiO2 is, as long as you ventilate and oxygenate reasonably well, the drop in pulmonary vascular resistance is very similar. And here are control lamps without PPHN to show that PPHN lamps have significantly high PVR. But what is really interesting is that subsequently, 60 minutes later, if you go and give these lamps nitric oxide, prior exposure to 100% oxygen resulted in significantly lower pulmonary vasodilator response to nitric oxide. So initiation of resuscitation with room air, as was promoted by our chairman, Dr. Ola Saugstad, results in better response to pulmonary vasodilators later in the NICU. And high exposure to oxygen results in poor response to pulmonary vasodilators. And this is secondary to superoxide-mediated inactivation of the nitric oxide cyclic GMP pathway. So this is where Ola's contribution to room air resuscitation has made such a big change. And this really opened my eyes and created a pathway for my academic success. So I owe a lot of my success to Ola and his talks that I had the fortune to listen to when I was a junior attending in many PAS meetings. So if you don't believe me, here is a slide from a pulmonary artery taken from a lamp that received 21% oxygen for 30 minutes. And this is 100% oxygen for 30 minutes, just 30 minutes. And here are pulmonary arteries, and here is the airway. And the red pigment here is superoxide anions. And you can see that just 30 minutes of exposure to 100% oxygen can result in significant damage to pulmonary arteries with oxidant injury with increased formation of superoxide anions. And we have previously shown that maintaining oxygen saturation between 90 and 97% results in significant decrease in pulmonary vascular resistance, whether the LAMP model is one of ductal ligation or meconium aspiration or a control LAMP. So this particular pink zone here with SATs between 90 and 97% tend to be the ones that are really useful. And that goes along with what is recommended by the European Vascular Disease, Pulmonary Vascular Disease Network of maintaining preductal SATs between 91 and 95% when pH is suspected or established. But one range will not help all babies. This is a curve from Dr. A. Brudal's textbook on congenital heart disease, which shows that the increase in PVR is dependent on pH. If you have acidosis, that exacerbates hypoxic pulmonary vasoconstriction. So for example, if you have a pH of 7.1, you need to maintain PO2 above 55 millimeters of mercury. If the pH is 7.2, it's much lower. 7.3, even lower. 7.4, it's even lower. So the cutoff where pulmonary vascular resistance increases, the so-called change point, is dependent on pH. So if you have a baby who is really acidotic, these babies require a slightly higher oxygen levels compared to babies that are not acidotic. So maintaining appropriate pH is also really important while managing babies with PPHN. So in babies with acidosis, consider targeting slightly higher oxygen, 93 to 98%, in the presence of acidosis or hypothermia, or when the FiO2 is low. Here is one more graph from a recent PAS meeting that was concluded in Toronto, where you can see that when the PaO2 goes below 50 millimeters of mercury, if the pH is high, there is not much of pulmonary vascular resistance increase. On the other hand, when the pH is below 725, especially 715, there's a huge increase in pulmonary vascular resistance. So avoiding a pH less than 725 is really important. However, hyperventilation with alkalotic pH is not good, because high pH tends to reduce cerebral perfusion and drops the carotid blood flow. So this should be avoided as well. So acidosis and hypoxemia increase PVR and reduce pulmonary blood flow. And alkalosis partially prevents hypoxic pulmonary vasoconstriction, but alkalosis or hypocarbia reduces carotid blood flow. So maintaining pH between 725 and 744 is probably optimal. Avoid alkalosis, avoid acidosis while managing babies with PPHN. The third thing to remember is race. For people who have dark skin pigmentation, it has been shown that they are more prone for what is called as occult hypoxemia. So occult hypoxemia is defined as a pulse oximetry with a saturation more than 90%, but when you do a blood gas, their SaO2, or oxygenation by co-oximetry, is less than 88%. And when you're managing patients with SATs between 92 and 96% children, what has been observed is that the incidence of occult hypoxemia is 13.4% in those infants, but in Black infants, the incidence is 29.3%, almost 2 times the incidence of occult hypoxemia. So children with dark pigmentation may need slightly higher oxygen saturation targets compared to children with light skin pigmentation. And that's an important thing to remember while managing babies with PPHN, because the incidence of PPHN is much higher among Black infants compared to white infants. The last thing is hypothermia. Hypothermia tends to shift the oxygen hemoglobin dissociation curve to the left. So if you want to maintain a PaO2 between 50 and 75 millimeters of mercury with normal oxygenation, normothermia, SATs between 92 and 96 are adequate. But when you're hypothermic, you tend to maintain the oxygen hemoglobin dissociation curve is shifted to the left, so you need to have slightly higher oxygenation. And so I tend to prefer SATs between 93 and 98 when babies are hypothermic. So to conclude oxygen section, if you have a baby who is term baby with PPHN, maintaining SATs between 90 and 97 are probably optimal, shown in the pink thing over here. On the other hand, if you are exposed to hypothermia, acidosis, dark skin pigmentation, or if your FiO2 is really low, then try to use a slightly higher range between 93 and 98%, but always try to avoid 99 and 100%, because those can be associated with high oxygenation levels and toxicity. So this is what is called as a precision medicine, where you target the exact pathophysiology in the infant and use appropriate oxygen saturations based on that baby's physiology. So the other aspect to think is, how much oxygen is the baby getting? What's the FiO2? For example, if you have a baby with PPHN whose prerectal SAT is 91% and postrectal SAT is 70%, but the baby is only on 30% oxygen and has severe pH on echo, yes, this oxygenation is okay, but giving this baby a bit more oxygen and increasing the oxygen to 45% can result in better oxygenation and reduce the severity of PPHN. So in this particular instance, the risk of hypoxic pulmonary vasoconstriction outweighs the risk of oxygen toxicity. On the other hand, if you have a baby with diaphragmatic hernia and a severe PPHN, and the SAT is 90%, the lactate is normal, there is no acidosis, but the FiO2 is already 80%. In this particular infant, it's probably better to closely monitor pH, lactate, and urine output and not increase oxygenation any further because the O2 is already pretty high. And so in this instance, the risk of oxygen toxicity outweighs the risk of hypoxic pulmonary vasoconstriction. So there is no cookbook algorithmic approach to optimal oxygenation in PPHN. Every baby is different. You have to look at the baby's pH, you have to look at the baby's lactate, urine output, baby's skin pigmentation, and baby's FiO2 before deciding the optimal oxygen level. So the next thing to important to remember is hemodynamic optimization. We need to optimize right ventricular function and left ventricular function in babies with PPHN. So I'm not an echocardiographer, so I really don't do echocardiography. And as many of you know, there are many new findings in echocardiography that are really important to remember. Here is an easy algorithm that I call as the rule of 3 about echo changes in PPHN. If the tricuspid regurgitation jet that you see over here has a velocity of more than 3 meters per second, that's a sign of PPHN. And this in turn results in a PA pressure, estimated PA pressure of more than 36 millimeters of mercury, and that's a sign of PPHN. If the right to left shunt across the PDA shunt is more than 30% of the cardiac cycle, that's a sign of PPHN. If the left ventricular eccentricity index, what that is that this is the normal left ventricle and here is the right ventricle. Normally, the left ventricle should be a nice circle and the right ventricle should be a nice crescent. In this case, D1, which is this diameter, and D2 by D1 is approximately 1. On the other hand, if there is pulmonary hypertension, the right ventricle is enlarged, the interventricular septum is deviated towards the left, in which case the D1 decreases and D2 increases. So the left ventricular eccentricity index is D2 by D1. And if this number is more than 1.3, that's again a sign of pulmonary hypertension. If the pulmonary arterial acceleration time is less than 90 milliseconds, that's a sign of pulmonary hypertension. Or if the PAAT by right ventricular ejection time is less than a third, that's a sign of pulmonary hypertension. RVET by PAAT, this is called as the pulmonary vascular resistance index. If that's more than 3, that's also a sign of pulmonary hypertension. And lastly, there is an entity called tricuspid annular plane systolic excursion. This is how much the tricuspid valve moves during systole. And if there is a lot of movement, that's good. If the movement is decreased, that's bad. And if that number is less, normally should be more than 9, but if it's less than 6, or especially if it's less than 4, this is a sign of severe pulmonary hypertension. So this is the rule of 3. If you remember the number 3, that will help you remember the various indices that you need to know while managing babies with undergoing an echocardiogram with PPHN. Let's talk about severe LV dysfunction. So here is a baby with here is the LV that's not contracting well at all. This baby's ejection fraction is 38%. As you know, normal ejection fraction should be above 50s, probably in the 55 to 60% range. And this baby's LV is not contracting much at all and has significant LV dysfunction, has a bidirectional PA and a left to right atrial shunt. So in this infant, what's happening is that this baby had asphyxia and was undergoing hypothermia, and there was significant LV dysfunction. LV dysfunction in turn results in elevated left atrial pressure. And because of that reason, although you have a right to left shunt across the PDA, you have a left to right shunt across the PFO, and that results in pulmonary venous hypertension. If you give inhaled NO to this baby, that results in pulmonary edema and worsening because the blood can't flow out due to obstruction due to high LA pressure. This is almost like having a potty or a toilet where there is a block, which is LV dysfunction, and here is pulmonary edema, that's the overflowing of the toilet. And if you flush this toilet, there is always a mess, and that's pulmonary edema when you use inhaled nitric oxide. On the other hand, the right treatment in this condition is to clear the obstruction, and once the obstruction is cleared, then you can go ahead and use inhaled nitric oxide. And so using milrinone to improve LV dysfunction should happen first, and once the LV dysfunction improves, then you can go ahead and use inhaled nitric oxide in these instances. But inhaled nitric oxide, milrinone should be used cautiously in babies with kidney injury, because if you have kidney injury, milrinone can cause systemic hypotension and cause problems. And as was shown by Patrick McNamara and his colleagues in Iowa, What they showed was in babies undergoing therapeutic hypothermia, use of milrinone can be associated with significant hypotension. And the reason for this is because these babies tended to have much higher creatinine and renal dysfunction compared to babies that were not undergoing hypothermia, and their creatinine was much lower. So renal dysfunction, commonly associated with HIE, can cause milrinone toxicity and cause systemic hypotension. One should be careful while using milrinone in these instances. The second thing to remember is the right ventricle. Normally, if you start increasing pulmonary arterial pressure, then the right ventricle compensates by causing right ventricular hypertrophy and much more effective pumping. So this is called as coupling or homeometric adaptation. On the other hand, when there is ischemia, hypoxemia, and myocardial stretching, and if there is severe increase in right ventricular afterload, the RV cannot keep up anymore and dilates and starts failing. And this is called uncoupling or heterotopic maladaptation. This is really important because unlike the left ventricle, which squeezes very well and then pumps blood into the systemic circulation against high afterload, the right ventricle has ineffective longitudinal contraction and is unable to handle high afterload. And for that reason, having sustained high afterload results in RV failure. And such sustained high afterload is very common in babies with PPHN undergoing cooling. So here is a baby with severe RV dysfunction. See, the RV is totally dilated here, and this RV is not really contracting well at all. And in these instances, this baby had a TAPSE of 3, which is really, really low, and a low fractional contraction. In such instances, a combination of 3 drugs is very effective. The first is prostaglandin E1, which helps to open up the ductus and relieves the afterload of the right ventricle. The second drug is milrinone, and the third drug is vasopressin. This is called the MVP combination: milrinone, vasopressin, and prostaglandin. And in combination, they can really help babies with severe PPHN where the ductus is getting constricted. So when you're using PGE1 in PPHN, you should make sure that you have the right indication. So the right indication for PGE1 in PPHN is presence of restrictive PDA with high RV afterload, systemic hypoperfusion due to left ventricular dysfunction due to low left ventricular preload, so there's not much blood coming to the systemic circulation, and this is an indication for PGE1. Once you give PGE1 opens up the ductus, and when the ductus is open, the right ventricular afterload decreases and can function much better, and the right to left shunt results in reduced RV afterload and improved systemic perfusion. Even getting blue blood through right to left shunt is better than having no blood supplying the lower part of the body. And this is a really sign of improvement because the RV afterload is reduced. And finally, when do you wean or stop PGE1 in PPHN? Once the RV function gets better and PPHN gets resolved, once the shunt starts becoming left to right in the PDA, then you should stop using PGE1. So if the respiratory status is improving, there is no more preductal to postductal SpO2 gradient, and the other therapies are de-escalating, and echocardiogram shows that the PVR, PA pressures are subsystemic. In these instances, it's important to stop PGE1 because if you continue to use PGE1 for too long, that can cause pulmonary edema and result in problems. So these are the indications for PGE1, especially when the RV afterload is high and the ductus is starting to get narrow. So here is an algorithm that I commonly use in PPHN. Due to shortage of time, I will skip this, but basically what you do is assess the baby. If there is pulmonary hypertension and if there is no left ventricular dysfunction, then you go ahead and use inhaled nitric oxide. And sometimes I use hydrocortisone here as well. And then if the baby has RV dysfunction or failure, then I prefer to use milrinone. If there is LV dysfunction, you avoid inhaled nitric oxide and use milrinone first, and then go ahead with treatment of PPHN. Maintain normal blood pressure is important, and if the blood pressure is low, many of these babies require pressors, and my personal preference is to use norepinephrine or vasopressin in these infants. So to conclude, what would a fetus do when encountered with pulmonary hypertension? It avoids hyperoxemia, so it's important to avoid hyperoxemia to avoid destruction of nitric oxide. It's important to recognize that perfusion is more important than oxygen. Having blue blood is better than no blood. Cyanosis with good perfusion is better than ischemia. Maintaining ductal patency just like a fetus, if the right ventricular pressures are suprasystemic, helps offload the right ventricular afterload. It's important to avoid very high systemic blood pressures, like the fetus, because that tends to cause significant LV afterload as well. So that's my last slide, and I'm happy to take any questions, and I thank you for your attention.
Thank you so much, Satyan. This was fabulous. Excellent, as always. I'm so impressed by, I mean, all your basic knowledge in physiology and your comprehensive reviews of this topic. It's just fantastic. Yeah, we have time for discussion and questions, and so far we have received a couple of questions from the audience. I would like to start out myself with a few comments and questions. First, a very simple question about cord milking. The umbilical cord is twisted. So before you do the milking, do you detwist the cord? Could you say a few words about that?
No, not really, because most often the ideal treatment for any baby would be delayed cord clamping. And the only times cord milking is preferred is when there is urgency with a non-vigorous baby. So we don't really spend time detwisting the cord. Our obstetricians just basically strip the cord 4 times the way it is. And it's interesting to see how beautifully the cord becomes pale when you milk. And then once you strip, you allow the placenta to refill the umbilical cord, and then you strip again to push more blood to the baby. And so we don't detwist the cord, and we just squeeze it hard and milk it. That's a great question, though. It's because some of these are really twisted quite a bit.
Yeah, well, because I've seen that people are recommending to detwist the cord, but apparently that's not needed. So
I don't, more than needed, I don't. If there is time, I would much rather practice delayed cord clamping than cord milking. If there is 60 seconds, 120 seconds, it might be better just to cause delayed cord clamping. But milking is predominantly done only when there is not much time. And in those instances, detwisting might take much longer. And that's my concern as well.
And my second question, I mean, I don't think you mentioned much about sildenafil. I saw you had it on your last slide. Could you say a few words about the indications? Does it substitute nitric oxide or?
Yeah, that's a fascinating question. I was running over. That's why I hit a few slides, and one of those was sildenafil. Sildenafil is a very effective drug, and in many parts of the world where we don't have access to inhaled nitric oxide, sildenafil is the #1 drug of choice in many of these instances, especially oral sildenafil. It works very well by being a PDE5 inhibitor, and more recently, colleagues in Montreal, Dr. Pierre Wintermark, have evaluated the use of sildenafil in babies with HIE as to whether it contributes to neuroprotection as well. And we have a new grant to evaluate that in sheep also. The biggest drawback of sildenafil is that it's not selective. It tends to cause systemic hypotension as well. And the incidence of systemic hypotension is very common in babies with PPHN, and for that reason, sildenafil tends to be less useful. We use it often as a second-line agent after giving inhaled nitric oxide because it tends to enhance the effect of inhaled nitric oxide when given as an intravenous agent, and we use it quite a bit. And we're also eagerly waiting for the trial, Contino trial that was completed in Europe, evaluating the use of sildenafil and nitric oxide in babies with diaphragmatic hernia. And that trial might shed new light on the use of sildenafil.
Okay. Then Gianluca Lista, you have a question or comment.
Thank you very much, Satyan. Excellent presentation. I have a question for you. The echocardiographic evaluation is very important in the diagnosis and management of PPHN, but is there a role for the cerebral nurse to monitor the pulmonary hypertension to understand if our intervention are with success or not?
Yes, definitely. So most babies with PPHN, we tend to place a cerebral NIRS because unlike pulse oximetry that only tells you arterial side of the story with oxygen, having NIRS helps you understand the venous side of the story and oxygen utilization as well. So it helps me guide exactly what FiO2 I should use. For example, if you have a baby who is saturating 90% and has an optimal cerebral NIRS, then that worries me less because the brain is utilizing this oxygen. On the other hand, if the baby is saturating 91% and the cerebral NIRS is showing a very low value, then that worries me that I'm not meeting the need of this tissue. And so I would rather maintain a slightly higher FiO2 and a slightly higher oxygen. So we use cerebral NIRS, and I find it very useful. The catch here is that in babies with severe HIE, where the brain metabolism has been hampered with, some of these babies' brains cannot utilize oxygen, in which case the extraction is so low that NIRS values tend to be fairly high. And in that situation, it's very difficult to use that for managing these infants. So that's one catch with babies with HIE. But otherwise, uniformly in all babies undergoing cooling that have PPH, and we use cerebral NIRS, and I find it very, very useful.
Thank you.
Thank you.
Yeah, we have a few questions from the audience. First from Victoria Lima. Do black babies need a special sensor for detecting hypo or hyperoxemia?
Dr. Lima, very nice to see you. Good. Thank you for joining the webinar. There are lots of studies being done, including in our own center, evaluating skin pigmentation. And there's 2 groups in Israel that are evaluating this as well. So there's a lot of research being done to see if we need a different type of sensor. We currently don't have a specific sensor for for black babies, but there are several groups and several companies working on it, and hopefully we'll have one soon. It's also not clear as to how much impact skin pigmentation does. So there are some prospective trials being conducted in babies right now, including one by Dr. Siefkes at UC Davis. We are systematically evaluating skin pigmentation and PaO2 levels, and we need to wait for those results to come back because many of these trials are done based on race and don't really quantify skin pigmentation. So what we are doing now is bring a cosmetic meter to identify exactly how dark the skin pigment is, and then look at the effect of pulse oximetry. So we're doing some new studies, and these are really important in this particular instance. But the fact remains that PPHN is a lot more common in black babies, and one of the causes could be that we miss a lot of occult hypoxemia.
Then I have to ask, because I think this is an interesting, important topic. So, you know, when we are talking about oxygenation in the delivery room, and that there's nomograms, oxygen saturation nomograms, do we need specific separate nomograms for black babies, do you think?
I think if the studies show that even with fetal hemoglobin, because most of the studies are done in adults with skin pigment, adults and children. There are very few baby studies. There are only like 3 or 4 studies done in neonates. So we really do not know if the skin pigmentation effect is much more prominent with adult hemoglobin or if it's also present with fetal hemoglobin. I think we haven't really ruled that out yet. If it turns out that fetal hemoglobin is also affected by skin pigmentation with pulse oximetry, I think we will have to come up with slightly higher oxygenation norms. And in fact, placental transfusion and delayed cord clamping itself is creating a bit of a shift in the nomograms now. And so maybe adding skin pigmentation to that will be important. So Vishal Kapadia's trial that you are a mentor to him, Dr. Saugstad, are looking at the OptiStar trial with slightly higher saturations. Hopefully he has enough babies with skin pigmentation that he can address that question as well. But that's an important question that needs to be addressed.
May I ask, first of all, thank you for a fantastic lesson, really. And may I ask, how fast is the pharmacologic effect of milrinone? Because I remember a clinical case that in which there was the diagnosis of this baby the baby was dying. The diagnosis was pulmonary hypertension, but there was pulmonary edema and left ventricular failure. And so I was called by phone, and I suggested to stop nitric oxide and to try with milrinone. I was really surprised that in a very short time, the baby improved dramatically. So very quickly ask myself if I did the right thing or was impossible so fast improvement. In any case, the babies didn't survive.
So you did two things, Dr. Professor Moretti. You stopped nitric oxide and started milrinone. It's possible that the benefit was more from stopping the nitric oxide than with starting the milrinone. If you don't give a loading dose, like a 50 milligram per kg loading dose of milrinone, the onset of action with just starting an infusion of milrinone takes anywhere from 4 to 6 hours. We recently concluded the milrinone in diaphragmatic hernia trial, and we are waiting for results to come back where we are monitoring hour by hour blood gases and stuff. So typically, we don't see an improvement with milrinone for 4 to 6 hours unless you give a very large loading dose. So my suspicion is that the baby got better because you stopped nitric oxide and stopped pulmonary flooding and pulmonary edema, and that resulted in improvement before even milrinone had a chance to kick in and help. So that would be my best guess, but typically, at least in studies without a loading dose, to get a steady state of milrinone, it takes a long time, a few hours. So I suspect the effect was not from milrinone.
In any case, the milrinone could have some good effect in the following hours. So
Yeah, definitely.
Okay,
yeah.
thank you very much.
Yeah, thank you.
Yeah, we have some more questions from the audience. One is asking about diagnostic criteria for pulmonary hypertension. I think you mentioned that, but
Yeah, so clinically, we tend to put a pulse ox in the right hand and also one on the foot to see preductal postductal difference, having labile hypoxemia, and obviously getting an echo of the criteria that we went over are various signs of pulmonary hypertension. So the diagnosis is mostly based on echocardiogram nowadays, and more in Europe more than in the US. Many of you are very well versed with doing echocardiograms, and that really helps in early diagnosis of pulmonary hypertension.
yeah. And then there's a question about the use of prostaglandin E1 to closes. Yeah.
Yeah.
Close
So the
one.
dose of PGE1 that we use is a little lower than the standard dose. We usually start at 0.01 to 0.025 mg per kg per minute. And then if the ductus is really closing and we need to go higher, we go to 0.05. So that's the range that we use. It's the same range that you use for maintaining ductal patency in congenital heart disease. We use the same dose. And PGE1, in addition to opening the ductus, also has pulmonary vasodilator effects, and so it may have a dual role to play in the management of PPHN. It can also cause systemic hypotension, and so that's something to be remembered with PGE1, and that doesn't really help if you have having systemic hypotension.
And then there's a question from Islam. Vasopressin use and how to wean it.
Yeah, so that's a great question. Let me quickly see if I can show you this slide. So vasopressin is really beneficial in refractory pulmonary hypertension and systemic hypotension. And the dose we use is 0.1 to 2 milliunits per kg per minute. We need to monitor pulse oximetry, blood gases, lactic acid, and blood pressure. The main problem with vasopressin is it tends to cause hyponatremia and reduced urine output. Oliguria is a big side effect. It can reduce mesenteric perfusion, and so there is some concern about feeding during this setting. So once the blood pressure starts getting better, we slowly wean the dose and bring it lower and lower. Many babies are stuck on a very low dose of vasopressin and tend to have sodium issues with this low dose. So we wean very slowly and take the baby off vasopressin. But hyponatremia is a very common problem. And so off late, we are not using too much of vasopressin, and we are preferring to use norepinephrine, which tends to be much better tolerated in some of these infants.
Yeah, there's one asking about if the records of this lecture is available, and I guess it is.
Yes.
For some time. Yeah. And then we have a question about inhaled iloprost.
Great, yeah. Inhaled iloprost is an effective prostacyclin derivative that's effective through inhaled route. As a third-line agent, it's fairly useful. When you start using inhaled nitric oxide and then you don't see a really good effect, and then you can consider using it, as I was showing in this algorithm that I went through really fast. So we typically treat with inhaled nitric oxide, see what kind of response we get. And if there is some RV dysfunction, we try milrinone first and then use PGI2. And this is where we use inhaled iloprost in these infants. And so as a second-line agent, it's quite effective. It has a short half-life, so it doesn't cause systemic hypotension. And so it's an effective agent. But we typically use it after trying inhaled nitric oxide and milrinone, and then use it as a third-line agent while managing these babies with pulmonary hypertension.
And then there's a question from Mohammed Badawi. Are you still recommending not doing cord milking preterm babies less than 28 weeks?
Yes, as I mentioned earlier, less than 28 weeks, there is a higher risk of intraventricular hemorrhage. So we do not do cord milking in any baby less than 28 weeks of gestation. And the study I was showing you was between 35 and 42 weeks of gestation. So these are term babies where it has been shown to reduce the incidence of HIE and need for therapeutic hypothermia. So in preterm babies, cord milking is definitely contraindicated.
Yeah. And then Maria Villander asks about, she thanks for a great talk, by the way, and asks you to say something about intact cord recitation compared to cord milking.
Yeah.
That's
So
another lecture, but you can, yeah.
that's another lecture. So intact cord recitation has been mainly studied in preterm infants for the most part, but there are some studies from Ola Anderson and his group in babies in Nepal, etc., where they have given oxygen and resuscitated babies with an intact cord. And they have shown better outcomes in those babies, but specifically pertaining to PPHN, there are not many studies. But having a higher hemoglobin does improve outcomes in PPHN, in my perspective. So I think that's something that needs to be investigated. There are trials going on with delayed cord clamping in congenital diaphragmatic hernia, and hopefully results from those studies will help us evaluate as to how delayed cord clamping might be beneficial in babies with PPHN as well. So we need to wait and see what the results show before we start doing it on our own.
Yeah, I think a couple of studies have been published also from Europe, and we recently listened to Ola Andersson. And my impression is that intact cord recitation compared with delayed cord clamping has not shown any benefits so far. I'm not aware of any study comparing intact cord recitation with the cord milking, but this is my understanding that so far we haven't been able to demonstrate any benefit.
You're absolutely right, Ola. The issue with intact cord resuscitation is that when you ventilate the lungs with positive pressure ventilation, it's not really sure how much of placental transfusion can happen when you compare it to babies that are on delayed cord clamping, where you stimulate them and they cry, creating negative intrathoracic pressure. That might be a much more effective way of placental transfusion than positive pressure ventilation. That might be one of the reasons.
Yeah, we're exceeding our time a little bit. Could we ask our president, President Moretti, can we go on for a few more minutes?
Yes, 5 minutes, yes.
Okay, do you mind, Satyan?
Oh, not at all.
A few more questions?
Sure.
Okay, so the next question is from Sven Baller. He asks about which drug of choice in case of arterial hypertension and pulmonary hypertension.
Sven, that's a great question. My first drug of choice is norepinephrine. I tend to use norepinephrine because it's shown to be fairly selective, and there are studies from France showing that the level of vasoconstriction that you get with norepinephrine is much lower than dopamine. So personally, I don't use dopamine in PPHN, and I prefer norepinephrine as my first line of drug. On the other hand, if the baby has good urine output and is tolerating well, the second choice would be vasopressin. So I tend to remain between norepinephrine and vasopressin. If the baby has significant ventricular dysfunction, either the right ventricular or left ventricular dysfunction, in those cases, using norepinephrine tends to cause very high afterload. In those cases, I tend to use epinephrine. So most often I use norepi if there is hypotension with good cardiac function, or epi if there is hypotension with poor cardiac function. So, and I typically don't use dopamine because of the non-selective nature of dopamine's effects.
And then Leonardo asks, what is the link between pulmonary vein stenosis and left ventricular dysfunction?
I'm not aware of a link, except that both left ventricular dysfunction and pulmonary vein stenosis both can cause post-capillary pulmonary hypertension. So there are two separate etiologies, but I'm not aware of a direct link. Patients with severe BPD can have both left ventricular dysfunction and pulmonary vein stenosis, but I'm not aware of a direct link between the two.
And then we have a question about treprostinil. Do you try it if inhaled nitric oxide is refractory?
Yes, there are some treprostinil or remodulin is being increasingly used in some centers. I personally only have experience with treprostinil in babies with BPD with pulmonary hypertension in the long run, not in acute pulmonary hypertension. So it is beneficial, but we typically use IV prostacyclin or epoprostenol in these babies for refractory to INO, and save treprostinil while managing chronic pulmonary hypertension. But there are some trials going on, including one in diaphragmatic hernia, where they're evaluating the use of treprostinil. So there might be more data coming through in a year or two on the use of treprostinil in INO refractory PPHN.
Okay. And final question, inhaled nitric oxide in premature babies, should I give it a try?
That's a loaded question. As you know, inhaled nitric oxide is not approved in preterm infants, but it's increasingly being used in many centers. So what we do is we do a proper echocardiogram, check and make sure the echocardiogram is good. And then if the echocardiogram shows clear-cut signs of pulmonary hypertension, then we go ahead and use inhaled nitric oxide in those babies. So the use is fairly limited, and that's what we do in these infants.
Yeah, I think that's all. Or we got one more. Yeah, there's another final question. The role of bosentan in pulmonary hypertension.
Yeah. So bosentan is an effective oral agent in babies with PPHN. So especially in diaphragmatic hernia, we tend to use bosentan once surgery is done, and if the baby is tolerating some trophic feeds, we tend to use bosentan in those infants. But since it's only available as an oral agent and not as an intravenous agent, babies who are not feeding, it's not an option. So we have to wait till the baby starts feeding, and then we can use bosentan. It's an endothelin blocker and works quite effectively in babies with pulmonary hypertension, especially with diaphragmatic hernia.
I see, yeah. Well, I think that was the whole list. And once again, Satyan, this was fabulous. Thank you so much. And it's 5 o'clock your time, and we really appreciate that you was willing to give this lecture. And it's been appreciated, I guess, from the whole audience. So with
Thank
this,
you very much, Ola. I mean,
we'll
Professor
close.
Moretti, Professor Lister, and you, Ola, I've learned so much from you ever since I was a fellow. I've been listening to your talks, reading your books, and all the three of you have heavily influenced my career. And without distant mentoring from all of you, I would have been nowhere. So I really appreciate all that you have done for my own career, and I really appreciate it. Thank you so much.
Thank
Thank
you.
you. That's very generous of you to say that. And before closing, I want to remind you about the next lecture in this module 2, which will be in September. We haven't decided the date yet, but very soon we'll give you the date. So with this, I will thank all of you. I will thank the audience. Thank you for very good questions, and thank the panel here, Gianluca Lista, and also Professor Moretti, and again, Satyan. Thank you so much, and I wish you a very, very good day today.
Thank you very much.
Have a
Thank
great
you very
day.
much. Bye-bye.